name is Alex Peters, and I am an outreach specialist with the Wisconsin Cancer Collaborative. Thank you all for joining today. Today, this call will be recorded, and the slides and recording will be made available shortly afterwards. If you are experiencing technical difficulty, please use the chat for assistance or the help options within Zoom. Today, all of the lines have been muted during the presentation, but during the Q&A part, feel free to unmute your lines and ask questions. Given the volume of virtual meetings and that our staff is all working remotely in separate locations, we apologize in advance for any network connectivity issues and will do our best to solve problems as they occur. We appreciate your flexibility. So we are delighted to have so many new people join us today, along with our existing members. For those who may not be as familiar with us, we are the Wisconsin Cancer Collaborative, Wisconsin's statewide comprehensive cancer coalition comprised of 140 organizations working together to reduce the burden of cancer for everyone in Wisconsin. If you are not yet a member, we'd love to have you join. Membership is free. If you are interested in joining, you can do so by following the link on the screen. And now let's go over the agenda for today's call. Since our first webinar on COVID-19 and cancer back in April, there have been a deluge of new studies about COVID-19 and cancer. We are hoping that our presenters today can help condense the themes from these studies rather than focus on a single study, meaning that today our webinar will take on more of a conversational tone. And with that, let's go over the agenda quickly for today. First, I'm going to go over a couple of new resources that we have added to our website and highlight a couple new ones that will be coming out shortly. After that, I will introduce Dr. Pat Remington, who is going to provide us with an update on COVID-19 cases in Wisconsin. Following that, we will move into a facilitated discussion with Dr. Noelle LoConte and Dr. Pat Remington. And then finally, at the end, we will have time to take your questions. So if you haven't yet, you should check out our COVID-19 and cancer resource page that we have on our website at wicancer.org. We have social media toolkits, we have links to numerous research articles, access to our past COVID-19 webinars, and a number of different fact sheets, including one with tips for local governments and businesses. And coming soon, we are very excited to share that we will have this nice fact sheet that is cancer tests and screenings, how to safely get tested for cancer during COVID-19. This was developed in partnership with the Wisconsin Well Women Program and Covering Wisconsin. And we will be sure to share this out once it is confirmed. And then finally, we want to put in our plug for our January webinar that will take place on a different time than it normally does. So January's webinar will take place on the third Thursday of the month on January 28th. And it will feature Dr. James Conway, and he will be discussing the COVID-19 vaccine. More details are to come, and registration will be opening soon. So with that, I will now introduce Dr. Pat Remington, and we are so thrilled to have him join us today. Dr. Remington received his undergraduate degree in microbiology and his medical degree from the University of Wisconsin. After completing an internship at Virginia Mason Hospital in Seattle, he trained at the CDC as an Epidemic Intelligence Service Officer assigned to the Michigan Health Department. As a preventative medicine resident in the Division of Nutrition at the CDC, and as part of the CDC Career Development Program when he obtained his MPH in epidemiology from the University of Minnesota. He was the Chief Medical Officer for Chronic Disease and Injury Prevention at the Wisconsin Division of Health for almost a decade and joined the Department of Population Health Sciences in 1997. Since that time, he has led the development and was the first director of the UW MPH program, the UW Population Health Institute, and the UW Preventative Medicine Residency Program, was the first Associate Director for Population Health Science in the Carbone Cancer Center, and was the inaugural Associate Dean for Public Health in the renamed School of Medicine and Public Health. Dr. Remington's current research examines ways to improve public health surveillance methods and outcomes. He led the development of the Wisconsin County Health Rankings, now a national program supported by the Robert Wood Johnson Foundation. With that, I will hand it over to Dr. Remington, who will be discussing the current status of COVID-19 in Wisconsin. Dr. Remington, feel free to unmute your mic and I will be advancing the slides for you.
Thank you, Alex, and it's great to be here. I consider my roots to be in cancer prevention and control. When I was at the State Health Department as the Chief Medical Officer, I oversaw the development, really the first chronic disease program we had was in cancer prevention and control, and in the CDC breast and cervical cancer program. Working with Paul Carbone, a statewide coalition of cancer organizations, and then obviously the Wisconsin Cancer Council. So I really do value the work that people do around the state and at the university in cancer prevention and control. It's a amazingly good work, but also really important work. And so what I thought I'd do today is spend a little bit of time on the data. I mean, you can't miss these data. They're in the news every day. I have a news feed that comes in first thing in the morning from UW Health all the way up to the World Health Organization. And it is really vexing, I think, to see how this virus has continued to outsmart us. As of, and this is as of actually yesterday, we see that in Wisconsin alone, we are approaching 4,000 deaths. I had predicted some time ago that we would have 5,000 deaths by the end of December, and I think that will be the case. Almost 20,000 people hospitalized, approaching 500,000 people with positive tests. And that is going to be close to 10% of the population. So the chances are, I bet you everyone on this call knows somebody who's tested positive. Maybe some people on the call have tested positive. And many of us know people who have died from COVID-19. So it's gone from, as Beth and I were talking in early March, something that we had just learned of, and it began to affect our life, now to the new reality. And it will continue at this pace. There's no end in sight. The vaccine is around the corner, but there are issues related to vaccine adoption. As people say, we not only need a vaccine, we need vaccinations. And so that's going to be a tremendous challenge. The final number on this graphic shows that we have over 2 million negative tests in a population of close to 6 million people. That means, again, these are test results, not people with test results, but there have been a lot of people getting tested, and that's good news. We need more testing for people who've potentially been exposed or have mild symptoms. And that's something that, you know, we've been far too incapable of reaching the demand. And I guess looking at the map, that you'll see that different parts of the state are in different stages of the outbreak. It began in urban centers in Milwaukee, the Brown County, Green Bay, and in Madison, particularly since September. But our rural areas have not been spared. In fact, there's some of the areas in the country with the highest rates of transmission. We think just because it's sparsely populated that it's not at risk, but we know that people in sparsely populated communities gather in close proximity, such as in bars and in restaurants. So next slide. And this shows the cumulative number of cases. Now, again, I like to say approaching 500,000 by the end of 2020. And notice the acceleration beginning in early September. There's been a lot of hypotheses as to why this happened in early September. Certainly going back to school was a contributor, but also the going inside. People were spending less time outdoors. And finally, I think in the 2 months leading up to the election, there was a lot of debate about the value of of masks and personal protection. So I think, again, the sense was we had learned a lot by the end of the summer, but clearly not enough to keep this pandemic from accelerating to really unprecedented levels. Next slide. And as you can see here, this is the regional variation with every county in the state. We wish we had some counties with lower medium rates of transmission. Some are going down or staying level, but again, we see tremendously high risk. And I think the general sense is, some have said that we should use this information to make individual decisions or make policies, but I think we're at such a stage within the state and within this country that we can't use individual community data to make good decisions. We need to assume that the virus is going to be in every community in the state. And in fact, one of the research studies that was recently reported said if it's not there now, it will be. So that lowering our guard in a place that has less community transmission is actually the wrong thing to do. We should be vigilant in places regardless of what the current level of community transmission is. So take-home message is, it doesn't matter where you are in Wisconsin, there's community transmission and all places are at risk. And next slide. And again, we know enough about the biology of SARS-CoV-2 and COVID-19 in that as cases increase, we are going to see serious disease. We're going to see people requiring hospitalization, admitted to the intensive care unit, and we're going to see deaths. And so this is not surprising. You can see in the last months, really since Thanksgiving, a drop in hospitalizations, and actually cases have leveled off a bit. Again, part of this may be the age distribution of people being infected, because we know younger people fare better than older people. People living in assisted living or in nursing homes fare much worse. So I wouldn't follow the death rate numbers so closely. What we really need to follow is the percent of cases that are positive. And more importantly, we need to be, we don't really have a surveillance system, but we want to be monitoring unsafe behaviors, people who are gathering in close proximity to others in indoor environments or not wearing masks. So that's the behavior we really want to be monitoring. Obviously, the downstream effects of high-risk behavior, hospitalizations, ICU bed occupancy, and hospital bed occupancy are important indicators. And we are in a crisis in this state. We're just bordering on, well, in fact, I would say we're bordering on calling out the National Guard, but we have done that. We're now getting assistance from our National Guard because we're on the precipice of exceeding our capacity to care for really sick patients. And next slide. And we know in public health, if there's one truism in public health, is no disease is randomly distributed. Disease and death in COVID-19 affects disadvantaged populations much more. And you can see this graphic shows on the left column the percent of the population. About 81% of Wisconsin residents self-identify as white. And you look at the next column, which is the percent of COVID-19, you can see it's overrepresented in persons of Hispanic or Latinx background, or people who self-identify as Black or American Indian. And on the right is an important piece of information, and that is the rate. Sometimes when you see COVID numbers, you will see actual counts. And I understand the importance from a healthcare delivery, service delivery perspective, it's important to understand burden, and the number of people is an important number, but really understanding risk allows us to help certain populations or target our interventions to those populations at highest risk. And you can see, but Hispanics or people of multiple racial background, or American Indians and Blacks, have significantly higher rates than whites or Asian Pacific Islanders. So those numbers really are important, in that these are the populations that are being affected most from the perspective of incidence. And then if you look at the downstream effects of incidence, you'll see higher rates of hospitalization and higher rates of death, because these are the populations with more rates of a pet visiting me. We have higher rates of comorbid conditions in these populations. So these are the populations affected the most. And next slide. Perfect timing. I see Dr. LoConte has joined us from her commitments with the National Institutes of Health. So I'll turn it over to Noelle to reflect on what you've seen, particularly clinically, maybe with a focus on the burden in the cancer population, either people at risk of or being treated for cancer.
Yeah, I think just totally riffing off the cuff here, I would agree with your assessment that we're on the verge of collapse of the healthcare system. Sorry, I got muted by the host. I think we're on the verge of collapse here, and I think the one thing we should be tracking that we're not is staff. Beds mean nothing if you don't have nurses and physicians to staff them, and respiratory therapists. So if I could put a data ask out there, that would be it. I think staff are really struggling right now, and we're looking at a long winter. Everybody knows that Counting Crows song about the smell of hospitals in winter. This winter is going to be really, really hard, I think. As far as specific to cancer patients, we're seeing lots and lots of our patients getting COVID. No surprise, mostly from people in their household that caught it, however. What we're not appreciating is that cancer patients are not always connecting the dots between the fact that when they get cancer, that's going to delay their treatment, sometimes significantly. So I think we have set questions. I'm looking to Beth here. Yeah.
Yes, we do. I will go ahead and transition this then over to Beth, who is our partnership manager, who's going to guide us through a facilitated discussion. And then at the end of that, we'll have some time to take questions from everybody on the line today. So with that, I'm going to hand it over to Beth.
Thank you, Alex, and thank you, Dr. Remington and Dr. LoConte, for your words. As we've kind of called this section today is our fireside chat. We thought it was kind of a fun way to say, how could we have the discussion and learn more? There's so many studies, there's so much information out there, but how can we just have a dialogue and a discussion about the questions that are top of mind from our membership and the individuals and partners we work with? So what we're going to do is just kind of bounce back and forth with questions for Dr. LoConte and Dr. Remington. And then also feel free to use the chat if there's additional thoughts or questions that people have as we're walking through these thoughts and ideas. So the first question we would like to pose to you, Dr. LoConte, is what is the risk of COVID to cancer survivors?
Mm-hmm. Yes, so I think when this all started, it was definitely kind of a pants on fire moment for me in medicine and in oncology, where we really try hard to practice extremely evidence-based medicine. Really, most of our decisions around treatment, at least, are based on rigorously conducted clinical trials. And when COVID happened, we did not know what to do. We were, frankly, beside ourselves. And every center was doing it differently. There was no consensus. It was a very, very hard time to be a physician. It was very uncomfortable. So when it first happened, we actually thought all cancer patients were at increased risk, whether you were on treatment, recently diagnosed 10 years ago, long-term survivor, status post bone marrow transplant, if you ever got chemo, if you didn't, whatever. And that was reflected in some of the early literature that came out of China that would suggest that those patients were indeed at risk and had serious complications. Since that time, we have had more studies that came out of New York City in particular, but also Italy to some degree, the Bergamo area of Italy, that have actually refuted that. And now I feel fairly confident in saying that unless you are on active treatment or status post an organ or bone marrow transplant, you are probably not at increased risk for either catching COVID or having serious complications. And I think the intent here with a fireside chat was not to drill into specific studies so much, but I would refer the listeners to a study that was published in the Journal of Clinical Oncology, looking at New York Presbyterian Hospital. And it showed that the cancer patients really didn't do much worse. And then there's been larger survivor studies showing really no increased risk at all. So I think we are telling patients to get through their treatment, to stay vigilant, as Dr. Remington said, but that their overall risk is likely not elevated. And we think that that will be reflected in where survivors fall in the vaccination phases as well, that they should not be top tier for vaccine.
Great, thank you, Dr. LoConte. Dr. Remington, so what do you feel that we could have done better if we had the chance to do it over? I think we need to get you unmuted.
I have to unmute. Yeah, no, I muted myself. In a way, I have two answers. One is that this virus is very well designed to defeat pretty much anything we do. So it knows when there's any weakness in our response by spreading before symptoms and by having a large portion of people infected who are asymptomatic. You know, when COVID came out early on, we thought it would act more like the other coronaviruses, SARS and MERS, which traditional public health tools completely eradicated those outbreaks and prevented SARS and MERS from becoming global pandemics. Mortality rates for SARS and MERS are on the 20 to 30 to even 40% rate, meaning 1 or 2 or 3 out of 10 people die with those. But what happened is that people developed symptoms and became contagious at about the same time. And a high portion of people infected became contagious. So the isolation and quarantine of exposed individuals, that traditional bread and butter public health approach worked tremendously. And I think when we learned about the epidemiology of COVID-19, the more we learned, the more we were astounded that people are contagious prior to symptoms, and a large portion of people, particularly young people, are asymptomatic. And if we'd known that, we might have just said, oh boy, this isolation and quarantine is going to be a mess. It's going to be a mess because we identify cases too early. Too late. They've already done the damage. You know, quarantining contacts is probably too late. You're probably quarantining people, a lot of people who are already infected. And so that was one thing that we could have learned. And then the better approach would have been to ramp up testing beyond any level we ever would have expected. We should have been developing the technology. Well, first of all, you know, would have been nice if we would have had the banks and the technology. But I remember I had a colleague whose husband worked in an ICU in Madison, and he was exposed to COVID patient. He was intubating COVID patients every day, and he couldn't get a test, even with a runny nose, because he didn't have a fever. And that to me was inexcusable, to have people who we had a high level of suspicion of, certainly of exposure. We should have just been rolling out tests left and right. And even today, you hear on national news that there are nurses, people involved in patient care, who cannot get routine testing. You know, if you're an NFL player, NBA player, you can get tested. If you're, you know, a politician, you can get tested. But if you're at the front line, you're a healthcare worker, to have challenges in getting tested is outrageous. So I think if there's one thing we could have done is admit, and this again, hindsight is 20/20. You know, I never would have expected that we would get to the point that isolation and quarantine is not going to work. And we've exhausted public health workers by, you know, the contact tracers. It's not an effective strategy. It was for SARS and MERS. Turns out not to be here. We should have really done intense testing, routine periodic testing for anybody with exposure. I can get into the politics of everybody should have stayed home and, you know, people wear masks. Obviously, those are a lot of individual decisions, but I think as a system, we should have implemented a very aggressive testing, and then intelligent quarantine, use of intelligent isolation and quarantine to known infected cases.
Great, thank you, Dr. Remington. Dr. LoConte, now looking at, you know, more the perspective from the cancer patient, what is the risk of starting or continuing chemotherapy during the pandemic?
If I can reflect maybe on the last question, question for you, Dr. Remington, would be, should we be testing frontline healthcare workers, which I think we're not currently unless they're symptomatic, but it seems to me that would be an opportunity as well.
I would agree. Yeah, I would agree, Noelle. I mean, I think so you asked why we aren't, and if it's resource constraint, just think of the cost of failure in that setting. So I think we need to just reimagine what the standards are for testing. And if you keep doing the same thing over and over again, you know, waiting for people to get symptoms or for outbreaks to be detected, you're too late. We're always behind this virus. The way you get ahead of it is by routine and rapid testing. You know, we've understood the role of antibody testing and of PCR, but I think rapid antigen testing, you know, as a healthcare system, we want everything to be perfect and precise and accurate. We're not comfortable with tests like rapid antigen testing that aren't perfect. But what makes them better is the rapid information. Rapid inaccurate information or less accurate information is much better than you know, the gold standard that comes too late. So I think yes, we should be testing many more people in a preventive strategy than we are.
Yeah, I agree. So the question posed to me was, what is the risk of continuing or starting chemotherapy? And again, just reflecting on March and April and being honest with myself about where I think we made mistakes. I think it was a real mistake to monkey around with people's potentially curative chemotherapy. And what I mean by that is we made treatments that were every 2 weeks into every 3 weeks to minimize hospital exposures. We made treatments that were all IV, partially oral, or all oral. We made follow-up scans every 6 months rather than what we were planning, which was every 3 months, in this kind of foolish hope that this would only be a problem for 6 or 8 weeks. And I think that did two things. I think that we undermine ourselves when we tell patients that we can kind of monkey around with things like that, but then we talk to them about the importance of, you know, rigorously following treatment, you know, clinical trial treatment protocols, for example. I think we undermine the scientific enterprise, but I think also we potentially compromise cure. I lose sleep over the fact that we may have lost opportunities to cure patients by making changes that we didn't know were sound from the scientific literature. So you probably know how I'm going to answer this question, which is, if a patient needs chemo, they should get chemo. That cancer does not stop for a pandemic, and I don't see a rapid end to this anytime soon. And so if your patient needs chemotherapy, they should start chemotherapy. I think with a few exceptions, I would not monkey around too much with curative intent chemotherapy. If the intent of therapy is life prolongation and quality of life, then potentially you could consider dropping aspects of treatment that maybe contribute to things like myelosuppression. But beyond that, I think it's really talking to patients about hand washing, mask wearing, not being in crowds, not going to Thanksgiving. And I will tell you That is a very difficult conversation when you've just told the patient they have 9 months to live and they connect the dots and realize this is their last Thanksgiving, most likely. Not traveling. Of course, when you get diagnosed with cancer, you get this bucket list and you want to do all these things, and we have to have really uncomfortable conversations with people about not doing those things right now. The New York Presbyterian study suggested that if a cancer patient gets hospitalized, their risk of being on a ventilator or being escalated to ICU level care is about 40%. So the goal needs to be to try to not have them get COVID, and if they get COVID, to try to not let it get bad enough that they need to be hospitalized. Of course, there's only so many treatments we have. I'm going to go through those in a later slide, but I think the other thing to consider here is drug shortages. So COVID has really put a big strain on the whole healthcare system. We talk about expanding testing, but one obvious implication of expanding testing is that the stuff that the lab was doing has to be done somewhere else. And so what we saw in cancer was, we're sending next generation sequencing, fancy molecular testing on all of our patients. We were doing a large amount of that in-house. So you could, within a week or two, get sort of the most actionable mutations back. We no longer can do that because all of that bench space has been now taken up by COVID testing. And so we're doing it as a send out, and that testing is now taking 4 to 5 weeks, which is a month delay in starting chemotherapy for somebody with symptomatic cancer can be a lot, can be an awful lot, can be the difference between getting treatment and not getting treatment. And then I think there's other drugs like FUDR, which is a drug we inject right into the liver, is basically there's none of it anywhere in this country. So patients with those liver pumps in place are just getting saline put in, very ineffective therapy. It's almost always generic drugs. So things like leucovorin, which we use in children all the time, used in GI cancers, 5-fluorouracil, which was invented at the UW but is now generic. These were made, with very low profit margins, and so and usually there's only 1 or 2 companies that make them, and if those companies go down because they can't get gloves for their line workers, for example, there's no drug, there's none to be had. And so I think we're seeing the limitations of kind of maximizing profit in the healthcare system. So I think about things like drug shortage. So I think it would be irresponsible to put like a liver pump in somebody right now. And I think pharmacies need to do very careful monitoring of like, what is the intent of therapy, and prioritizing curative intent therapy when there's drug shortages. So those would be my thoughts on that matter.
Thank you, Dr. LoConte. Definitely difficult and difficult choices. So how we can look at the bigger community and how we can all play a role in helping. We know we've talked about masking and social distancing, but we know that there is some skepticism to its effectiveness, really despite there being some very thorough evidence indicating the effectiveness. So Dr. Remington, given this, I know you spoke a little bit about the importance of testing and how that really should have maybe been a bigger priority in the beginning, and obviously moving forward needs to remain a critical step in it. But do you have other items to discuss in harm reduction as we look at our approaches to COVID?
Sure, I have a lot to say about this, so you might have to just pull the plug on this. First of all, I think this pandemic has been diagnostic. It's been like a stress test to our healthcare and our public health system. It's also been diagnostic on our society in general. We've understood that some people fundamentally believe that individualism and freedom of choice trumps, so to speak, collectivism and responsibility for others. And that's sort of been, that's your political opinion, and, thank you for that, but it doesn't really affect me. It's just an argument that comes up every once in a while when we have an election. Actually not. It comes up every time you go into a gas station or go into a hardware store in rural areas of this state. You see people exhibiting their philosophical belief about the role that individual responsibility takes in protecting the health of others. And I think there's fundamental differences in beliefs, that it's not my job to protect you. It's my job to, be free and able to make decisions. So I don't think there's so much debate on what masks, do or don't do, and how effective they are in social distancing. There's just a fundamental difference of belief about our responsibility to each other. And that's been, troubling for people in public health to find out how pervasive this feeling is. Now, whenever you learn something about your friends or neighbors or colleagues or society, you should dig deeper and say, why is that the case? And I think for many people in society that are struggling, getting by, they have, maybe they're in a low wage occupation, their rent, their cell phone service, food, there's not enough money to make ends meet. And so imagine being in that situation, and then somebody comes along and tells you to do something to help others. It just doesn't rise to the level of importance. So I think that if anything, we need to listen to people more and use this as an opportunity to understand what's really going on in people's lives. And I think what we've found is that there's a lot of suffering, a lot of really disadvantage in society. I mean, we've known that. We've seen levels of opioid abuse. Cigarette smoking rates are still high in low income populations. Suicide rates, particularly among the young, are up. We have high rates of unemployment and poverty, and the list is long. And then you add this request is to wear a mask and keep socially distant. And I'm sorry, for a large portion of the population, it doesn't really matter. So I think we can keep harping on the fact that people are not being smart when they don't wear a mask and they don't practice safe behaviors. But I think we should just scratch beneath the surface and try and understand why. Walk in their shoes, try and figure out why they might be feeling this way. And I think it just reflects poorly on society that we've come to a place where healthcare costs are out of reach for many people. We think, a $6,000 or $9,000 out of pocket is not bad for a healthcare system. Well, wait a second. If you're making $25,000, that just took half your take-home pay. The other half is taken in rent. That is too high. So let alone home ownership and sort of the American dream. So I just think, believe me, I talk about, wearing a mask and staying safe, stay home if you can, if you go out, socially distant, and, careful hand washing and all of the public health recommendations. But underneath that, we need to just get back and understand why people in society might be responding in this way. And it's not just because they don't care, it's because they're, in many cases, struggling with all the other things that, they've had to deal with. So, I mean, that's kind of a soapbox response to, this being a stress test and a way to diagnose the problems, not just in our healthcare system and our public health system, but in society in general. And I see a question about flu numbers being down. Boy, I don't think we're going to see flu. In the Southern Hemisphere in Australia, they had winter, last summer. They saw no influenza. I think what we've learned is that respiratory viruses, we have never paid attention to respiratory viruses so much, right? You go to work, teachers go to school. I am married to, you saw my wife come into this room. She did early childhood education. And sure enough, when that started, she'd bring it home and then I'd get it. And we just share, viruses. Well, now we understand that if you actually stay, physically distant, outside if you can, and isolate, colds and, influenza don't connect. So a measure of society's response to COVID will be whether we see influenza circulating. And right now we are not. We're not seeing it in Wisconsin. We're not seeing it in this country. Now, again, if we get careless, we can not only see COVID respond in a fourth or fifth wave, but we could see influenza come. It's just waiting for people to connect. The virus is still there. It's just waiting for us to connect between, person to person. But if we stay home if you can, stay socially distant, wear a mask, good hand hygiene, we won't see as much influenza. And that's been borne out in the Southern Hemisphere.
Thank you, Dr. Remington. Dr. LoConte, so as we're talking about staying socially distant and, kind of keeping the space, it also impacts how we're doing health visits. So as we're all kind of now far more familiar with Zoom, we know that telemedicine has become kind of an approach that has exploded this year in how we're able to use it in medicine. So could you help us with the best approaches that you've seen for using oncology telemedicine?
Yep. So this was something so I started my practice in 2000, was when I graduated from med school, and we were having conversations then about telemedicine, and it took a global pandemic for us to get it together. But this may be one of the sort of lasting effects of COVID, hopefully. And I think it's a wonderful tool, but I do think that it has the potential to amplify disparities in certain populations as well. And I think that although it's certainly better than a phone call, it's not as good as an in-person evaluation for certain patients. So just starting with like logistics, you want to make sure, first of all, that the provider has their camera ideally at forehead. This is from Toby Campbell, that this can facilitate the patient seeing our expressions better. And we want to try to control our verbal responses, so our mm-hms and our yeps and our I sees, because it's interesting, in oncology we're trained to do that, actually, to verbally affirm what the patient is telling us, but that causes a funny sort of glitch in the audio when you do it over telemedicine. So using things like nodding or thumbs up, like those kind of things are better approaches with telemedicine. I have seen concerns about HIPAA, meaning that a lot of us are sort of doing these telemedicine visits kind of interspersed between our in-person visits, and we physically do not have space in our clinic for us to have a separate telemedicine room. And so we are literally putting providers in closets, psychology rooms, conference rooms. Many of us go up and use our professional office, which thankfully is connected to the hospital at the UW, but that's not always the case. But some of us are doing it in the workroom, and I think there is concern there about patients can overhear conversations about other patients. They can see things that have HIPAA on them. So being very careful about where is your space. I think for me as a provider that sometimes does telemedicine from my home, I have privacy concerns. You can see my children in the background here. Like, there are certain patients I don't really want them to know that information about me. So how do we make that better? Most of the platforms that I've seen, we can't use Zoom, we can't use FaceTime because of HIPAA concerns, we can't use Google Hangout. And the platform that we have does not allow you to blur your background. So if I could do a wish list, like that would be wish list number one, is let the provider blur their background. There are state border issues. So when the pandemic first happened, they all kind of went away temporarily, but they're now starting to come back, meaning I am licensed in Wisconsin, but I sometimes do telemedicine with patients outside of Wisconsin, and that is no longer okay. So we are making our Illinois patients drive up to see us in person only because of this legal thing that jeopardizes my license.
Wow.
So we would really like that to go away, because there's no reason why a person in South Beloit can't do telemedicine, but a person in Beloit can do telemedicine. It doesn't make sense.
So Noelle, if they drove across the border to like a stop and go in Wisconsin, could you have
Then
a
it's
telemedicine
okay.
visit?
Yeah, and that's what a lot of providers are doing, are instructing their patients to drive up and park the car.
Wow.
Yeah. Wow. I think telemedicine, the other thing it's illuminated is that you really need to be on time. Patients don't like sitting in front of a blank screen for a long time, and many oncologists are double booked or run late. For any number of reasons, physicians can run late, and they often do. And you really can't be late for telemedicine. So it has forced a lot of us to truncate and not to double book. And what's happening is patients are not being seen that need to be seen potentially, or we're having to say, like, I'm going to reschedule you for a week. We're going to continue this conversation in a week. So I think it would be better from a practice perspective to batch all of your telemedicines at the beginning of your day if you can. The problem is that's usually when you want to also see your chemo patients, because it takes a long time for these patients to see the physician, get their chemo, have their observation period, have the nursing assessment, and then go home. So it's a squeeze on the system again. We definitely need tech support for patients. So I just want to say God bless all the grandchildren out there who taught grandma how to FaceTime, because that was like a lifesaver. But there's plenty of people out there that don't know how to use it. They don't know if they have a webcam. They don't understand browsers. And many of these platforms you can only use on Explorer or Chrome or whatever, and they don't have any idea what I'm talking about. But we really need to build out that infrastructure for tech support for patients within the hospital. And that's a job opportunity, which I know there's a lot of people searching for jobs. So that would be a good idea. And then I think there are rural inequity issues. So videos are only as good as your Wi-Fi, and some people just don't have good Wi-Fi. If I can only phone call somebody, I can't assess them for things like jaundice, how their respiratory rate looks, you know, just general assessment of how they're doing. And it makes me very uncomfortable to, over the phone, clear somebody to start their next round of chemotherapy. So I do worry about rural patients being left behind in this whole thing, and us thinking about broadband not as a, you know, business enterprise or an information enterprise, but really being an access to care enterprise. So those are my thoughts.
Thank you, Dr. LoConte. So Dr. Remington, kind of looking to the future now. So as we know that there is a COVID vaccine, but you've also mentioned that a vaccine is just a vaccine. We also need people to be vaccinated. So what do you think the efforts around the COVID vaccination will look like?
Well, I'd like to go back to Noelle's comment, which is a silver lining. And it is interesting that some things, we will come through this, and I think we will advance some technology. I think hopefully hang on to the things that make people's lives better. And in particular, I think, you know, being able to connect with a physician when normally you wouldn't be able to at all. You just couldn't come in. I can't tell you how many times I've been able to meet with people that there's no way I would have been able to meet with them. It was just too hard, and now we've been able to connect. So I think there is a silver lining. Unfortunately, I don't think there'll be a silver lining in COVID vaccination. We know there's an undercurrent of people who've been hesitant about vaccination. One is the overestimate of the potential harms, but the other undercurrent I've already talked about is the sense that I don't, you know, I should have the freedom and the liberty to do whatever I want, and I'm not willing to take a risk to protect others. And so that's the general vaccine hesitancy or anti-vax views, that I don't want to assume any responsibility or assume any risk just because I could contribute to the reduction in the risk of an outbreak, and people getting sick who are immune compromised or can't otherwise be vaccinated. And so I think we're going to find that is going to be not the exception, but that will be the rule. Surveys coming out right now, about 50% of people say they're going to voluntarily step up and get vaccinated. 50% of people say they won't. So that's a tremendously high rate. And I would argue, you know, we haven't talked about, we've talked about risk behavior and the importance of, you know, staying home if you can, and, you know, keep outdoors and socially distant, all the things we know about moderating our own risk. But what we haven't talked about is our own risk tolerance. I've decided that I'm despite the picture, I'm over 60 years of age. I'm kidding. I'm 66 years of age. And I wake up some mornings and say, how did I get to be 66 in a high risk group? But that just happens. So I'm in a high risk group. I've decided I have a low risk tolerance. I think some of my kids have a pretty high risk tolerance in that, you know, they look at it and they say, that I'm willing to accept a few risks. I'm willing to send my kids to school. In other words, we have one of my kids has 3 kids. They're 2 of them are in school in person. So they've accepted that risk because they're willing to accept the risk that they might become sick. the benefit is in-person education. And I respect that. But what is going to happen is that if you are an elderly person, if you have chronic illness, if you are in a nursing home, and we only get to 50% vaccination, it's just cut your risk in half. It hasn't eliminated the risk of community transmission. So nothing will change for people who are at risk of death or serious illness with COVID. Your calculus when you get up in the morning with 50% vaccine rates is you've just cut out about half the people that could get you sick, but half remain, and so it's not going to change much if we only get to 50% vaccine rates. Now we're at about 10% of infection rates. So combination of natural infection, which is going to kill a lot of people, 5,000, probably 7,000 by spring. This might become, about 10,000 people die in Wisconsin from cancer and heart disease each, and we might be at that level before a year goes by. This could become the leading cause of death. And if that's the case, then a lot of people are gonna have to die before we get herd immunity. It would be nice if we could get to 80, 90%, achieve herd immunity, and then the isolation and quarantine, we can get the workforce back, the public health workforce, we can get contact tracers to find those few outbreaks and actually do good testing. We'll have testing capacity, we'll have the contact tracers back because we'll have herd immunity, and so we can get ahead of the virus. If we only get to 40, 50% vaccination rates, nothing will really change, particularly for people at high risk of getting sick. Those people, and I could put myself in that, I won't change what I'm doing. I basically stay at home. I'm basically quarantined. I can't afford to change that just because half the people are protected. I don't know who they are if I go out to a store, a restaurant, or a bar. So I won't risk it.
Dr. Remington, there was a follow-up question that came in just about the merits of various vaccines. And what is the likelihood, do you think, that there will be consumer choice regarding which type of vaccine one can access?
Oh, I see that, Regina. Good to hear from you. Yeah. Boy, that's the other end of the spectrum, that people are, actually wanting to choose the different types of vaccine. I have to be perfectly honest, I haven't thought about that. Whether you want you want to balance the side effects. I think that's going to be really hard to do. Side effects happen. It's actually an intent of the vaccine. You want to get the immune system geared up. So sometimes people say, well, that really made me feel sick, but that's actually kind of how the vaccine works. So I'm not sure I'd shop around for vaccines with fewer side effects. The other thing is that's a pretty individual response. And so my view is that if FDA, gives emergency use authorization and they're deemed to be safe, that I think the bigger question will be, what health system are you in? Are you in a community that can, that has, freezers that can keep, the vaccine, the Pfizer vaccine, cold chain intact? So I think it'll be more what's available by your provider, your health system. So it's a good question. I'm not sure I have an answer to that, because I think they're all, in this country, they seem to be all pretty effective, and they seem to have low complication rates, very low, serious complication rates. So I think any vaccine is better than no vaccine, and I don't think there'd be any evidence on one better than the other.
Thank you, Dr. Remington. We've talked about as a team that people are becoming vaccine consumers and learning more that there are different types of vaccines for the same disease. So it's kind of been interesting to see the community kind of embrace the conversations we've had around vaccines and be very interested in the science behind them. So it'll be interesting to see as it rolls out. So thank you, Regina, for the question. Dr. LoConte, so kind of along the lines of the chemotherapy question, but again to oncology patients, how do you see radiation and surgery, and should that be delayed, or should we continue to move forward, such as with the chemotherapy question?
Mhm. I think radiation, if needed, should not be delayed. I think surgery, there's a little more nuance there, in that there are surgeries that should not be delayed, which is to say removal of the tumor. And then there are surgeries we do for oncology patients that probably could and should be delayed, things like ostomy reversals, breast reconstruction potentially. So sort of the number 2 surgeries after we do the big surgery to take out the primary tumor. Now I say that, my main practice is in GI oncology, and I say that realizing what a tremendous drag ostomies are on patients' self-esteem and quality of life. But we are dealing with, as was alluded to earlier in the talk, a real limited amount of hospital beds. And I think if you are doing an elective surgery or procedure that would take a hospital bed, you need to think long and hard about, does this really need to be done now, or can this be done in 6 months to a year? Radiation doesn't take up a hospital bed, so I think it's the equation is much more different there, and most of those patients need that treatment somewhat urgently. So I would say proceed with radiation.
Thank you, Dr. LoConte. I think we have time for maybe one more question and then just some final comments. So to you, Dr. Remington, I know this is kind of the big open-ended question, right? When do you foresee an end to this pandemic?
Well, I don't see an end to the pandemic. I think, first of all, this virus is never going to go away. You know, when AIDS HIV came out in the early 80s, we were on a steep learning curve, finding out its origin, finding out how it, the epidemiology and the risk. And we thought someday we'd see an end of HIV. Well, HIV is going to be with us forever. It's like the common cold. It's like, there are some viruses you can eradicate. They're very relatively few. Obviously, smallpox was eradicated, and we may be on, to eradicate polio. But I don't think we have. I teach a class, an undergraduate class, and the elements needed to eradicate a disease, and SARS-CoV-2 and COVID-19 not close to meeting those criteria. So this virus will be around for a long, long time. And so what we're going to see is a transition from pandemic to endemic, that the virus will be circulating, and we'll need to keep vaccine rates high. We'll need to keep vigilant in outbreak detection. So we'll need a public health system. We'll need a healthcare system for better treatments. So we're going to shift from pandemic response, hopefully, by next summer, if we can get vaccine rates up. If we can't, then that's just going to take a lot longer. It's going to take several years and more people to get sick and more people to die. And so we have a choice as a society, and we have to figure out how we can get immunity rates high enough so that we can arrest person-to-person transmission. And when it happens, we can find it and stop it. Because if we can't, then we're going to have to get the herd immunity somehow. And if we don't get it through vaccines, we'll get it through natural illness with the associated, 1 or 2 or 3% mortality rate for everybody infected.
Okay, great. One final question that just popped up is, do you think the vaccines will be tested and approved for children?
Well, I heard that question come to the sort of vaccine czar, and the answer was it's going to be a while because there are no trials yet. The general sense is that kids are sources of infection, but are going to be fairly low priority for vaccination. And so I think what we're going to see is some experience in younger adults and older children, and maybe sort of ongoing vaccine monitoring systems will be in place to understand efficacy in sort of observational research as opposed to experimental research. But I think the idea is that we can achieve herd immunity by vaccinating first those are at highest risk of either getting infected or dying as a result of infection. And that's the idea of healthcare workers and long-term care facility residents. And then, we have a long way to go to develop vaccines for kids. But I mean, I think this person being interviewed said they're advocating for this, but I think right now, as Noelle said, we need to focus our resources at the highest priority. And I would say kids are probably, on vaccine allocation lists are going to be at the bottom of the list.
Well, great. Thank you so much, Dr. Remington and Dr. LoConte. We are going to have a poll pop up now for all of our members. So if you wouldn't mind, just before you jump off today, giving us a little bit of feedback and comments on today's webinar. Dr. LoConte, Dr. Remington, thank you so much for your comments. This has just been so insightful, and thank you for joining us for our fireside chat. If there are any other additional thoughts, or Dr. Remington or Dr. LoConte, you want to close with, or?
Well, I would just close by saying, first of all, I'm not a frontline healthcare worker, so I'm not going to be priority 1A. I'm a physician by training, but I have the good fortune of being able to do my work remotely. So Noelle and all those on the phone that are at the front line, thanks for the work that you do. It's amazing. It really is a call to duty. And the last thing is everybody on this call is a leader in your community. Start with your family and your friends and your social networks. But this is where we need everybody to help. We are not going to get to where we want to be just by having, Governor Evers or the next president making declarations. It's going to be person to person, credible advice to your friends and family and colleagues. And so we have a lot of work to do, and we need all the help we can. So, I appreciate everybody, participating, but just do everything you can to spread, good information and encourage people to get vaccinated.
Perfect. I dropped in the chat some thoughts I had about if your patient tests positive, and I'm always happy to take questions from anybody.
Great. Thank you so much. And thank you to everybody for joining. Please mark your calendars for our January webinar and look in your email box for the follow-up information on how to register and participate in January. So thank you very much. Have a wonderful end of 2020.
Thanks, Beth. Thanks, everybody.